My name is Joost Wiersinga. I work as an infectious disease physician in Amsterdam University Medical Center, and I'm also part of the Surviving Sepsis Campaign Guideline Committee for 2026. And here I would like to discuss with you the new Surviving Sepsis Campaign Guidelines that has just been published in March 2026. If I can start with just giving an overview of what these guidelines are. So I think that the Surviving Sepsis Campaign Guidelines truly has become a global movement. So it is a large panel of experts from around the world. Actually, there are 69 members from over 23 countries from all continents across the world, and the chairs, and it was a difficult task, but they did a tremendous job. The chairs for this iteration were Hallie Prescott and Massimo Antonelli. So the Surviving Sepsis Campaign Guidelines have been endorsed by over 20 societies across the world. So there is the Society of Critical Care Medicine, the European counterpart, ESCMID, but also numerous of others. And I think that we perhaps cannot underscore the importance and the significance of these guidelines because they are being used in thousands and perhaps even more than 10,000 hospitals and clinics across the world. So for the 2026 guidelines, there are now 129 statements, and these are mostly recommendations, sometimes conditional, sometimes strong recommendations, depending on the level of evidence, but of course also some good clinical practice statements. So they are on screening and early management, infection, hemodynamic management, respiratory support, adjunctive therapies, additional supportive management, transition of care. Also, more and more emphasis is put on that, and also long-term outcomes. So for the infection section, there were 25 statements. And I would like just to highlight a couple of them, and there are some new ones. So first of all, the timing of antibiotics. So we do know that early antibiotics, that's just effective to reduce mortality in sepsis. That has been studied and shown over and over again. But, a big but, of course, this must also be balanced against undesirable effects. So, for instance, from large observational studies, we do know that a third or more of patients initially diagnosed with sepsis turn out to have a non-infectious condition. So when you have a too early closure that the sepsis call is made, antibiotics are given, sometimes another diagnosis, which is the correct diagnosis, can be missed. And then that's just one example of the potential side effects of giving antibiotics too soon. And of course, also resistance development, microbiome disruption, etc. And it is difficult, these studies, because the timing is always different. For instance, variation in the definition of time zero. Anyway, the recommendation is now as follows, that on the timing of antibiotics, that if shock is present, so if you have septic shock, it is very clear. Strong recommendation to administer antimicrobial therapy immediately, and ideally within 1 hour of recognition. If shock is absent, but sepsis really the definite diagnosis, same story. Give antibiotics as soon as possible. However, if shock is absent and sepsis is possible, then there's more time, and it's advised to have a rapid assessment of infection versus non-infectious causes of illness, and then it is advised to administer antimicrobial therapy within 3 hours if concerns of infection persist. If you go to another recommendation, that's on the use of biomarkers to start or stop antibiotics or antimicrobials. So on the use of procalcitonin, that's an important one then to consider. There is the carryover recommendation of last time that for adults with possible or probable sepsis or septic shock, it is suggested to use clinical evaluation alone over procalcitonin plus clinical evaluation to start antimicrobial therapy. But perhaps the more interesting question is, can you use procalcitonin to decide when to discontinue, when to stop antimicrobials? Well, more and more studies have been done on that, and indeed it is advised that you can use procalcitonin now in those circumstances when the optimal duration of antibiotic therapy is unsure. And that is interesting because it was also shown in the last version of the Surviving Sepsis Campaign Guidelines. Often we do know for how long to treat sepsis caused by pneumonia, caused by urinary tract infection, caused by intra-abdominal infection, and there was a literature overview made, and often short duration is just as good as longer duration. So in most cases, we already know that antibiotics should not be given for too long. And of course, that's also important from an antibiotic stewardship principle, the importance of daily assessment for de-escalation of antimicrobials. So that is also now more emphasized in the current edition of these guidelines. Also in line, source control. So it is now advised for adults with sepsis or septic shock to rapidly evaluate for specific anatomical diagnosis or source of infection, and then try to do early source control over late source control. And then there's this time cutoff given of 6 hours. So try to have source control if needed within 6 hours of diagnosis in case when source control is needed. So then there's a new recommendation on empiric anaerobic coverage. So when we take one step back, what we do in everyday clinical practice, so we do know that anaerobic infection is rare. Sometimes it is seen in anaerobic infection, limited to the abdomen, necrotizing soft tissue infection, head and neck infections. But although it is uncommon, empiric anti-anaerobic coverage is common. And a lot of the antibiotics we prescribe every day to our patients, like amoxiclav, piptazo, meropenem, clindamycin, etc., they all have a very broad anaerobic coverage. So a point prevalence study across more than 1,000 ICUs in 88 countries across the globe did show that only 1.2% of patients had an anaerobic pathogen causing their infection, but 50% of those patients were on anti-anaerobic coverage. So we do know that depletion of the normal gut microbiome by anti-anaerobic antibiotics is associated with worse outcomes. So to summarize, when you use empiric anti-antibiotic therapy for sepsis, the key thing is to save the anaerobic microbiota, because very few critically ill patients require anti-anaerobic antibiotics, but most receive them anyway. This causes profound disruption to the gut microbiome, and microbiome disruption can contribute to organ failure, which can lead to worse clinical outcome. So anaerobic sparing therapy should thus be a therapeutic strategy in sepsis. So that leads to a new recommendation in Surviving Sepsis Campaign Guidelines. For adults with sepsis or septic shock, it is without risk factors for anaerobic infection. It is suggested to use an empiric antibiotic regime without anti-anaerobic coverage. And of course, when a certain antibiotic is given because of its spectrum to also cover multi-drug resistant pathogens, then that is more important. But if you have the choice, make it more narrow. Try to spare the anaerobic antibiotics. Try to spare the anaerobes. Another updated recommendation is on prolonged infusion of beta-lactam antibiotics. So the rationale is as follows. usually more than 40% of patients treated with beta-lactam antibiotics on the ICU may not achieve concentrations above the MIC during 50 to 100% of the dosing interval. And a beta-lactam administration via continuous infusion leads to sustained concentrations throughout the dosing interval, longer time above MIC, and improved bacterial eradication. So that sounds like it makes sense. And now we also have more evidence available. So we have the results of the BLINK-3 study, a very large study conducted across more than 7,000 patients across more than 100 ICUs around the world. The intervention was continuous administration of the beta-lactams, mostly peptazo, meropenem, first intermittent infusion. And the nice thing was that this very large trial was also added to a meta-analysis that was published on the same time. And there was a favorable outcome for those patients treated with continuous infusion. So the revised recommendation reads as follows. For adults with sepsis or septic shock, we recommend using prolonged infusion of beta-lactams for maintenance after an initial loading dose over bolus administration. That's a strong recommendation. I think that the greatest benefit of this is in short half-life beta-lactams like peptazo, meropenem, and perhaps less beneficial for those beta-lactams with a long half-life like ceftriaxone. There is an implementation challenge because it requires infusion pumps, can be difficult in low research settings, and there's this identified research gap about the impact on antimicrobial resistance, although there was no clear signal towards this in the meta-analysis. To highlight a last new recommendation, that one is on the use of selective decontamination of the digestive tract. So just one background on the selective decontamination of the digestive tract. So it is a preventive infection control measure in mechanically ventilated patients. It targets the aerobic pathogens, but preserves the anaerobic gut microbiome. So the regimes used for this STD differ, but usually you have an oropharyngeal paste consisting of colistin, tobamycin, nystatin, and a short course of IV antibiotics, for instance 4 days of ceftriaxone. The aim is to decrease the rate of ventilator-associated pneumonia, bloodstreams, infections, and thus lower mortality. And there's this ongoing debate, is it effective in high resistance settings? Does it impact antimicrobial resistance, etc.? The very nice thing is that the new development is that now the Sudoku trial has been published. A very large trial among almost 6,000 patients comparing STD versus standard of care with a primary outcome of 90-day mortality. Very recently, not included in the guidelines, but good to mention, is the follow-up of the Sudoku trial that did not only include the patients from Australia, but also from Canada, increasing the size to more than 9,000 patients, also with the same trial design and intervention, and a very recent meta-analysis that included the Sudoku trial. The meta-analysis did show this positive protective effect of the use of STD. So we now have this new recommendation in mechanically ventilated adults with sepsis or septic shock in units with a low prevalence of antimicrobial resistance. It is suggested to use selective decontamination of the digestive tract. Conditional recommendation, moderate certainty of evidence. So with the recent update of the Sudoku trial, there was also this editorial published in the New England stating that there is this accumulating evidence that STD confers benefits without clear harms. But perhaps Can be new and people can still be reluctant to introduce it. So it is suggested in this editorial that a pragmatic approach could be to start with SAD in intubated patients with acute traumatic or hemorrhagic brain injury, given their high nosocomial infection risk and signals of mortality benefit consistent with ceftriaxone prophylaxis data. So perhaps we should identify those patients that will most likely benefit from this treatment and leverage our microbiome insights to restore colonization resistance in critical illness. And perhaps we should also redefine SAD as microbiome modulation therapy. But anyway, that's more future work. I think this is already a significant new recommendation. So taking it all together, so in the Surviving Sepsis Campaign Guidelines 2026, we now have 129 statements, 25 address the infection, the infection management. I highlighted a couple of them. I also think that on the future development of the guidelines, this has been great work, but I think we have to emphasize that often the implementation gap is larger than the knowledge gap. So still a lot of work to do. Thank you very much.